Hello. In this video, we are going to speak about considerations for the assessment of right hemisphere damage, traumatic brain injury, and motor disorders, especially apraxia and dysarthria. These all affect communication, whether receptively or expressively, and we are going to speak about considerations for assessment. We're not going to speak about the details and all of these intricate details that go into the assessment process itself, but considerations for each disorder. And generally, when you construct an evaluation for one of these disorders, you go through steps, and many of these steps, as you could see, are common among these disorders. But we are going to speak about different highlights and different considerations that you would focus on when evaluating one of these disorders as they relate to communication, speech and language. In terms of right hemisphere, first keep in mind that even though language rules, the lexicon, and the mechanics of language, the building blocks of language, are localized in the left hemisphere for the majority of the population, more than 98%. Have language localized in the left hemisphere. So in terms of the right hemisphere, it gives you the overall picture of things, holistic processing. However, in order to contribute to language processing, the right hemisphere has to communicate with the left hemisphere and work very closely with it in order to get the raw material, to get the language concepts and the language, the grammar and so on. So we can't think of the right hemisphere and the left hemisphere working separately. They have to work together in order to give you an integrated kind of communication functioning. So the right hemisphere, especially the frontal lobe of the right hemisphere, works with the frontal lobe of the left hemisphere to regulate, to make you have attention skills. Attention, there is no single area in the brain where you can point to and say, this is the area for attention. You can think of attention as a function, something that happens as a result of several areas in the frontal, mostly in the frontal cortex, and these areas in the frontal cortex also are connected with areas in the parietal cortex. There's a significant pathway that connects the frontal and the parietal cortices called the frontoparietal kind of pathway, and that contributes significantly to building your IQ. Building your intelligence. So now imagine, for example, that there are 10 or 12 areas, for example, in the frontal cortex, right and left, and some in the parietal cortex. All of these together make a circuit. When you connect the circuit, and from both ends, you just connect it, what you get is the ability to focus attention, to channel attention, to switch attention. There are many components of attention. So in any case, attention is an outcome of the connectivity of circuits that connect right hemisphere, frontal lobe of the right hemisphere with the frontal lobe of the left hemisphere with the parietal cortices, left and right. However, the frontal lobe of the right hemisphere is thought to be more dominant in attention. So it contributes a little bit, more to attention than the left hemisphere. So in any case, the frontal lobes of the brain are central to attention. And this is why someone has a car accident where the frontal part of the brain is affected that is going to cause significant attention and significant working memory problems, because working memory is also a function of the right hemisphere. I mean the frontal lobe, I mean, of the brain, especially left and right. Right hemisphere, the right hemisphere also controls emotional prosody. Emotional prosody refers to the meaning, the emotional content, the meaning that you put in your tone of voice, the meaning that you put in loudness. When you raise your voice, you change your pitch. All of that conveys emotional meaning. So, for example, when you say the word "get out of here," you can say it jokingly, you can say it seriously, really meaning it, "get out of here." Or you can say it when, say someone, something is going to hit someone, and all of a sudden you want to alert the person, "get out of here, get out of here." So you can say it in many different ways, and the way that you say it is going to indicate the kind of emotion that you intend. How do you blend? How do you integrate the emotion that you intend to convey? Or sometimes it is conveyed without your intention. How do you integrate that with the tone of your voice? How do you, when you are excited, how do you, does your emotion blend in with the tone of your voice to convey in your voice that you are excited, or you are sarcastic, or you are angry, you are sad? All of these emotions, how do you blend them with the tone of your voice to make so that your voice colors your words with your emotions? The area that is across in the right hemisphere, there are two areas. An area that is across from Broca's area. We know Broca's area only exists in the left hemisphere. We know that Wernicke's area only exists in the left hemisphere. Now, the area that is similar, mirror image of Broca's area, that is found in the right hemisphere, even though it is similar in anatomy, we do not call it Broca's area. We call it the area analogous to Broca's. It is like the mirror, like I have a left hand, right hand, they are mirror images of each other. So the area that is analogous to Broca's area, and that is found in the right hemisphere, is the area that enables you to express yourself using a tone of voice and blending it with the intended emotion, or the emotion that reflects your state at the time of the statement or the question that you make. So this area particularly enables you to integrate your emotions with your tone of voice. Then in terms when you express yourself, that is expressive. Just like Broca's area has to do with expression, this area across, on the right hemisphere that's analogous, enables you to express by blending your tone of voice with the appropriate, or the blending your emotion with the tone of voice that is appropriate with your emotion, whether that emotion is intended or not intended. So that is one area, the function of the right hemisphere. Obviously, if someone has a stroke or brain damage that affects this area in the right hemisphere, you can imagine that this person will not be able to speak in a way as to convey emotions using their voice. The area that's analogous to Wernicke's area, that area is across on the right hemisphere, and the temporal cortex, and the posterior temporal gyrus, and the posterior superior temporal gyrus. And again, it is a mirror image of Wernicke's area. We know Wernicke's area is dominant for comprehension, for processing spoken language. Now, the area across in the right hemisphere that is analogous to Wernicke's, this area also is receptive in nature. It enables you to comprehend the emotions or the emotional content in the speech of others, When you listen to others, you read the tone of voice. You can tell if they are sarcastic, if they are happy, if they are sad, if they are joking, and so on. All this wide range of emotions you can comprehend only because the area that is analogous to Wernicke's enables you to do so. You can now imagine if someone has a stroke or brain damage that impacts this area, the person will have significant difficulties in processing the speech of others, particularly in reading their emotions. For example, the person might listen to someone and that person who is speaking is angry. And yet, the one who has right hemisphere damage in this area is going to think there is nothing wrong. They are not going to be able to read sarcasm. They might look at, you say something, even though you are joking, they might misunderstand it and think you are serious. So all of these things, emotional prosody is critical in communication, in terms of social relationships, between, on any level, between a husband and a wife, between a child and the parent, and so on. And also it becomes even worse as you extend the relationships beyond the family, for outside and the social circles and so on. So that could cause significant socialization problems and difficulty with comprehension of meaning, especially of spoken language, as the person listens to, other people speaking, and also when they express themselves. The right hemisphere is dominant for discourse. Discourse is what goes beyond the sentence level. So words, sentences, comprehension of words and sentences, this is semantics. You go beyond the sentence. If you speak about 2 or more sentences, you are speaking about the realm of discourse. And there's discourse, pragmatics, deal with the organization of your verbal output, sequencing, putting things in a certain way to, to regulate your communication with others. It also includes written language as well. So in pragmatics means you have a goal. You focus on your goal for communicating your message, and how whatever you do to make yourself effective in conveying that goal and conveying that message very effectively as you plan and intended, that is pragmatics. This is why you call someone is pragmatic. It means they have a goal and they work toward that goal consistently and persistently until they achieve it. So discourse, say for example, you read a paragraph, you want to understand the whole idea of the paragraph so that you can actually summarize the entire paragraph in one sentence. You want to be able to sequence the paragraph. One sentence connects with the other, the sentence that comes before it and the sentence that comes after it, and the one sentence in a paragraph connects with the topic sentence at the beginning of the paragraph. One sentence connects with the conclusion of the paragraph. So the whole paragraph is like a close kind of mesh of all strings coming together and making a fabric that makes that paragraph so strong that if you take one little sentence out of it, you are going to have the whole thing is going to show that there is something missing. Discourse relies significantly on cognitive skills, especially working memory and attention skills. And so it is an area where cognitive skills merge with linguistic skills. It's the most complex use of language. So someone, when they produce discourse, someone with the right hemisphere, you can count on it that you will identify discourse problems. Their ability to comprehend discourse, their ability to construct discourse, to express themselves. And this is what you look for. So all of these areas are areas that you need to focus on when you evaluate right hemisphere damage. Humor, the ability to evaluate, to produce humor, and the ability to comprehend humor. And again, that is right hemisphere function because humor depends on abstract language. You say something and then you just come, build and build, and you come to one piece at the end and you just pop and say it, and then you get your effect. You have to be very meticulous. You have to time a joke. You have to time, the humor you use very, very precisely in many ways. And if you do not, it is going to backfire. So people with right hemisphere damage are going to have difficulty making humor and comprehending humor, which again is going to have an impact on social communication. The ability to give indirect requests. A direct request will be, please pass the salt. Please open the door. That is a request. But if you say open the door, that is a command. That's an order. And in the culture, we learn to be polite. So instead of saying open the door, when you say it open the door, it implies some kind of authority, some kind of that you are ordering someone. And the culture made it so that, if you are polite, you are going to achieve your goal, and with pleasure. So we use expressions like, please open the door. That is a request. It is not an indirect request. So remember again, order is open the door. And if you want to request, I'm just requesting, making a request, please open the door. If you want to make it an indirect request, you would do this. Would you please open the door? So you add a modal verb at the beginning. Would you? Could you please do this for me? Now listen to this. Can you count from 1 to 10? That is an indirect request. Say, can you count from 1 to 10? Someone with the right hemisphere damage is going to go, okay, yes, I can. And that's it. They give you an answer. They take it literally. They are not taking it as a request. They take it as a matter of fact. Do you have the ability to count from 1 to 10? So that is also a red flag. So when you say to someone, can you count from 1 to 10? They should say 1, 2, 3, 4, 5, and so on. So again, this is one of the areas where they take things concretely, and they might take an indirect request as a statement of fact. Yes, they answer yes or no. Non-literal or abstract language, we know that the left hemisphere is going to interpret things literally. It is going to kind of, if you say the same statement I said, can you count from 1 to 10? You say, oh, yes, I can. And let's move on. That's left hemisphere. And right hemisphere would say, well, this is not what the person is asking me. They are asking me to actually do it, to count from 1 to 10. So anything that is abstract, the right hemisphere is dominant for. And also, keep in mind, research shows that as this is Broca's area here, and as you go from the Broca's area has proceduralized forms of language, syntax, and it has things that you say you do not even think about. What kind of rule am I going to use to make my sentence that I'm making now? So it is proceduralized. You do it whether you are dreaming, you are awake, without thinking, because you have listened to these forms for millions and millions of times throughout your life. Now, as you go from one sentence level and you go to this 2 sentences, or you make a little paragraph or a story, the frontal parts of the brain become more engaged. So if you have, say, 2 sentences, you have to go farther to the front, farther away from Broca's area, because the longer your verbal output, the longer it is, the more attention you need and the more working memory you need, and these are found in the right and left hemispheres, frontal lobes. So the more complex the language is, the far forward that you go into the frontal lobes of the brain to engage them more. So again, in order to be able to understand abstract language, where the meaning is not in a particular word, the meaning is usually outside. You have to take a sentence, put it with another sentence, and kind of extract meaning out of these two. That is a right hemisphere function. So all of these areas, again, have to be evaluated when you evaluate right hemisphere damage, to see, since these are the functions. And you want to see if someone has difficulty in these functions, you find evaluation instruments that enable you to evaluate these. And you can count on the instruments that are available to be able to actually to have items to cover many of these areas. In terms of causes of right hemisphere damage, there are many different causes, most often cerebrovascular disease, cerebrovascular accidents. Traumatic brain injury, and then the tumors also can cause that, because the bigger the tumor grows, the more it pushes on areas around it, and when it pushes, it's going to sever and cut and put pressure on these areas. And a tumor usually also has other inflammatory processes surrounding it, which is going to complicate problems. And then neurotoxicity. Also infections, certain kinds of infections are going to also could cause problems in the right hemisphere. In terms of symptoms, first, for a list, complete list of symptoms, refer to page 209. One of the most common symptoms is left-sided neglect, where if you left-sided, it means you are going to take the line of symmetry from, this area here, and you split the face in half. So you have right side, left side, and this right side has its own nerves. It has its own muscles that are mirror images of the other side. So now, left-sided neglect means, because the right side of the brain controls the left side of the body, that side is going to be affected. Vision is going to affected in this area, and that is exhibited by the patient. Typically, if you give them a picture of a clock, something that is, say, rounded, and you say, draw this clock or draw this flower, they are going to make exactly like half. They would draw half, and then the other half is not there. So, and there are many other problems where the person might even have lack of awareness of the left side of the body. For example, when they comb their hair, they might just comb the right side, and they do not pay attention to the left side. So, it's a very interesting and yet complex disorder, but you typically encounter it, and that's a big sign to show that the person has right hemisphere damage. You look for attention deficit, because again, the right hemisphere, especially the frontal lobe, is, could be involved, and that shows as decreased vigilance, decreased awareness, and decreased selective attention. Like if you have, different things, or several people are speaking, and the person has to focus on someone in particular, they will have a tough time. Like, say, in a party or in the presence of noise. So they would have difficulty paying attention just in the presence of many distractors. Emotional prosody deficits, and I explained extensively why. And linguistic prosody deficits. Linguistic prosody. Prosody is basically the intonation of the language. Intonation comes from tone. How do you intone your language so that you raise your pitch, you lower your pitch, you raise your loudness, you raise your loudness, lower your loudness, in order to continue to be dynamic and to make the nervous system of the person you are communicating with always staying alert and focused on what you want to say to them. Otherwise, if you keep your tone flat and you keep your loudness the same, that is monotone. We call this monotonous, and that is going to make the person listening to you basically habituate to your tone, and they might fall asleep, literally fall asleep. They will be very bored, and that's going to make their attention affected. They will not be able to process what you say effectively. So, linguistic prosody has to do with that ability to intone, raise your pitch and lower it, and loudness up and down. And these match particular emotions. For example, when you are so excited, you are going to raise your pitch at the end. Sentences typically have, when you speak in sentences, you drop your pitch at the end. So they are lower pitch at the end, like this. Yeah, I just went to the store today. But if you want to ask a question, or to express surprise, or to express, anger, or you are going to raise pitch at the end. So one goes down this way and one goes up when you raise pitch and when there are emotional situations. Discourse deficits, again, these have to do with how you construct your verbal output. It shows in conversation, in the ability to make conversation or to tell a story, and in the ability to comprehend a conversation or to comprehend a story or anything that is beyond a paragraph. So the specific language areas that are impacted and that you will look for, you want to see, to evaluate, to see if these areas are impacted and which ones are more impacted than others. So these basically are the focus of the evaluation that you as an SLP are going to conduct. First, the first two areas have to do with discourse, comprehension of narratives and production of narratives. Narratives are things that you say by yourself that are beyond one sentence. Like say, tell me a story. Or describe for me, for example, how your day went. So it is uninterrupted. You keep going on and you are the speaker in a narrative. It can be a story. It can be telling something that happened to you through the day. It can be retelling something that that someone tells you. And conversation is the difference between this and conversation is that it has back and forth. It has turn taking. So the ability to comprehend narratives should be evaluated because typically in right hemisphere syndrome, it is impacted. And then the ability to produce narratives, to construct a cohesive, organized narrative where things are connected with each other, where things are, for example, coherent and cohesive. Dates, the earlier dates come first and the later dates come after, and things are in sequence and in order. When you say something, you are not getting off topic. You are focused on the topic that you are speaking about. You are not switching topics as you speak, for example, all of a sudden. And also, you do not have ambiguities and obscurities. Your effectiveness in producing a narrative is almost measured by how frequently people ask you questions. Like, what do you mean? And how did that happen? And when people do that, then there is a need. That means that you are not really doing as you should in constructing the narrative. You need to sequence it so that you anticipate people's questions and you construct it so that when you finish it, then people, get the ideas without having a need to ask a question. Remember, the need to ask a question it means that there is a gap in that information that you are getting. And the more gaps there are, the more questions that you would expect. So the first two things have to do with the ability to produce narratives and comprehend narratives. And the people with right hemisphere damage would have difficulty comprehending the meaning of an entire paragraph, the meaning of a little story that is 3 or 4 sentences, what is implied, things that you construct by adding one sentence to the next, to the next, to the next, and then extracting a meaning out of that. So, for example, for example, say the girl told her mother that she didn't want her mother to buy the dress for her. The mother insisted that she was going to buy the dress. The girl said, well, if this is the case, I'm not going to go to the party. I'm not going to really, you can buy the dress, but I'm not going to go to the party. We didn't say here that the girl was angry, but by constructing these 3 sentences together, by connecting this with that, then you understand that the girl is very angry. Why should my mother buy my own dress when I am the one who's gonna wear it, and all of this? You can infer that someone with right hemisphere damage is not gonna be able to put one with this next with the next sentence, so that they can just extract meaning that is not found directly or directly stated in these sentences. Then, emotional prosody, 2 items here have to do with emotional prosody. Again, producing emotional prosody, as I explained, and understanding emotional prosody of others. So both of these areas are language areas because they are about communication. When you communicate, you do not just use words, you communicate with body language, and you communicate with linguistic forms as well. And your effectiveness in doing so, especially in conversation, is to integrate your linguistic output with your nonverbal tools that you use, facial expressions, eye contact, hand gestures, body language, and all of that. So the people with right hemisphere damage have difficulty expressing and understanding or comprehending someone's tone of voice. And so both of these two, they have to do with emotional prosody, expression and reception. Discourse pragmatics, as I explained before, these are areas that are speech-language areas. It's the highest level of language. It requires a lot of attention. It requires a lot of memory functions. It is a frontal brain function. And pragmatics is the area that begins developing right after birth, and it never stops to develop. No matter how long you live, but the more people you know, the more cultures that you get aware, that you get exposed to, the more that you learn about their manners and how you can adapt the way you communicate to get to understand and communicate with people from different parts of the world and different parts of the country in a constructive and effective way. So discourse pragmatics, again, is an area that needs to be evaluated extensively in right hemisphere damage. You ask people to tell you stories, summarize. For example, you can tell them a story, or if they have watched a movie or read a book, that will be a good way of getting them to tell you a narrative, to give you a narrative. Also, discourse pragmatics, you look for the social components of discourse, like turn-taking, using politeness forms, and so on. You also will evaluate the ability to comprehend non-literal language or abstract language, and the ability to produce abstract language as well. For example, idioms, inferences, proverbs, absurd statements, making jokes, metaphors. All of these are, some kinds of indirect implied or hidden meaning. All of them do, in any case, you do not find the words saying the meaning. You have to kind of derive the meaning by connecting words or connecting multiple sentences together to abstract some kind of meaning out of them. In TBA, traumatic brain injury, that could hit right hemisphere, left hemisphere, the back of the brain, the middle of the side of the brain, the front. It is random, and it depends. The damage is going to depend on where it is in the brain and how extensive, how severe that damage is, and the sequel of events in the brain that occur as a result of that trauma. So when we assess people with traumatic brain injury, we need to be aware of aspects of the disorder. For example, where the damage is going to impact the functioning of that particular area where the injury takes place, and it will have an implications for treatment, for diagnosis, for goals, and so on. As I mentioned, the TBI is a very diverse, very unpredicted area where damage can happen in any place with any level of severity depending on the conditions of the accident. So the goals for diagnosis and treatment are going to depend on the kind of injury that someone gets. For example, if it's a car accident versus a sports-related injury, why do you do the evaluation? What is the patient's goal? The patient's goal might be to go back to college. It could be that the person is retired and they don't need to go to work, or they might not be able to go to work at all. Maybe initially in the first step, they would like to just find a way to communicate as they continue to recover. So goals are going to be different. You focus on the individual patient that you have. There are many direct causes of TBI, obviously, and there are some direct ones that have to do with the impact itself and which area in the brain is impacted. These are the direct causes. And then there are indirect causes that occur as a result of an area, for example, that is damaged in a particular location. So these are called indirect causes. For example, if an area, let's say the temporal cortex here, is damaged. Someone has somehow an accident where they receive a hit here, and that damages, the temporal cortex. That is going to affect their ability to learn. So the damage itself, the physical damage in the anatomy, to the anatomy of the area here, that is the direct cause. So if it's a car accident, whatever it is, and it just causes, whether the skull breaks or that there's no break, but the area of the brain beneath that area is impacted and is damaged, then that is the direct anatomic cause of the problem. Then the indirect will be, since this area, the temporal cortex, has to do with memory, and it has to do with comprehension of speech and identification of speech and so on, then if the anatomy is altered or damaged, is impaired, then the functions of that area, like learning and being able to comprehend information, that is going to be affected. Then the indirect cause is of that damage. The indirect result, is a learning disability, difficulty with comprehension. Someone would have an intellectual disability or psychiatric disorder. All of these can be indirect causes or indirect actually results of the brain damage that results from traumatic brain injury. So we think about most of these are things that have to do with the software in other words. And the direct causes have to do with the hardware, with the anatomy, the physical things that you actually touch. These are damaged. And then what you can store on these areas and how they can do the function of these areas, then these are this indirect outcome. TBI, there are many different classifications. I mean, not different, like they are all complementary, but different forms, different ways of classifying TBI. And all of them are important, all of them are necessary. No, like one doesn't make up for the other. So first we identify or classify TBI based on the severity. And the Glasgow Coma Scale is a world recognized instrument for kind of evaluating the severity. So it goes from mild to moderate to severe, simply. Mild TBI, moderate or severe. Sometimes you find combinations, mild to moderate or moderate to severe. It depends. Sometimes it's not clear-cut. And then you also classify TBI based on the general cause. So the first one is the severity. How severe is it? And then the general cause. What caused it? It's a blunt, injury. Something like hits, but there's no penetration. It's like when you hit something, like say you take like a cup of Jello, and you just hit it so hard, like this. It doesn't break the cup, but it's going to make the material dislocated. So on one side, where the Jello is supposed to be sticking to the cup here, it is separated. And then it is all smashed on the other side, in the opposite side, against the skull, the wall of the skull on the other side. So you have a lot of many axons, many neurons are pulled away, torn away from the area that they reside in, and then squished and pushed, slammed to the other side. So even though there is no skull fracture, then you have this kind of damage, because the brain is very close in consistency to Jello or to toothpaste even. So there's also penetrating injury, where, say, a worker is using a tool and the nail just goes bang and it goes into their head. It penetrates the skull. Or there's a blast, and that blast in like especially in a military or, some kind of, whatever, a blast that might occur, it could also cause damage in the brain, even though in some cases the skull is not opened, but the tissue inside is severely affected. You know that sound, certain levels of sound can actually kill a human being. So now the third way to classify TBI is anatomic. What areas of the brain are affected? So you say, okay, there's focal damage. For example, a bullet, someone is in for whatever reason they have a bullet in a particular area. That bullet, it just hits one particular location or penetrates through, and but everything is localized. So in one particular, area. Or it could be diffuse, like the situation here that we have, where, say a car accident, and the typically you go back and then go forward, just hit very hard the front and then go back again. So you end up, if you were to make an experiment and have a cup of Jello and just hit it very hard, sorry, I became more enthusiastic, hit it very hard here, that's going to cause that dislodging of the Jello on this side to make it go and, moved and squished to the other side, just like this. So this side, becomes empty, and this side becomes all jammed. In that case, you have multiple problems. You have damage in several areas. Number one, there's the back area, and then the front area, and the side. And different areas also could be impacted in different ways. So that is diffuse injury based on the anatomy. So the anatomy can be focal injury or diffuse injury. And then the pathophysiology in terms of, is it a primary TBI or secondary TBI? So let's look at the primary and secondary. First, the primary, in terms of the physiology, the primary impact is going to have to do with the actual anatomy again. So say the primary effect, or the skull broke, or there is a fracture, there's a laceration, there's a diffuse axonal injury. It has to do with the anatomy. And then the secondary effect is going to deal with what happened as a result of damaging or altering that anatomy. So, for example, there's a laceration, and as a result of that laceration, their blood vessels break. As a result of so the blood vessel breakage is secondary effect because the laceration just severed it. And a secondary effect will be the blood that gets out of the blood vessel is going to also cause accumulation in different areas. And then these accumulations will cause further problems. All of these are secondary. But the primary effects are the physical damage that takes place as a result of the TBI. So, secondary effects include intracranial hematoma. Hematoma, hemia, H-A-I-M-A, means blood from Latin. And then toma means mass. So hematoma is an accumulation of blood, usually clotted blood. Accumulation of a blood outside of a blood vessel somewhere. And when you have that accumulation is going to put pressure because if a blood vessel is severed, it's going to continue to leak blood, and the blood is going to continue to put pressure on the brain. And if that blood vessel is big, the pressure is going to continue above and push down on the brain. It could push huge parts of the brain down toward the brain stem. And gradually, if that's severe enough, that you have the brain is like a cone or like a funnel. So you have big areas that are supposed to reside in large areas here in the skull. They are pushed down and like into a grinder almost. And as you keep pushing down, you kill axons, you damage neurons, you cause leakage of all the substances in the neurons out and the blood. So gradually, if that is significant enough, in just a matter of hours, the person could be dead because so much pressure now pushes down on the brain stem. The brain stem gets compressed and dislocated, and that could lead to death. So one of these intracranial hematomas, again, accumulation or pooling of blood that get due to severing of blood vessels, could be epidural, sometimes also called extradural. So the dura mater, remember the little three layers that cover the brain: dura mater, arachnoid membrane, and the pia mater. So when you say dura mater, it means that the dura is stuck to the skull, and in the area that is this is not the and the dura mater is actually separated from the skull, and the blood accumulates between the skull and between the dura mater. So the dura mater is still attached to the arachnoid membrane, still attached to the and the arachnoid membrane is still attached to the pia mater. The three of them are all compressed down, and there's the wall of the skull, and then you have the accumulation of the blood between the skull and the dura mater. So, or it could be subdural, that the dura is still attached to the skull, the blood vessel bursts, and then you are going to have the blood pooling under the skull, under the dura. So this is why it's called subdural, beneath the dura. This is a common area for rupturing of blood vessels, because the arachnoid membrane that is beneath the dura, that is an area where it has many blood vessels. So if one breaks, it is going to cause pooling, and that pooling is going to increase over time as the blood vessel or vessels continue to leak blood, and then you continue to put pressure on the areas that are beneath the blood pool. There's also intracerebral hematomas, and these are going to basically the blood vessel, the leakage is going to basically continue to push down. In this case, it is not on the surface, it is inside, it is deeper in the, like for example in here, there's a blood vessel that broke deeper in the white matter or deeper in the brain. So that is going to also cause significant problems as the pooling takes place. It's going to push down on the areas around it, which means severing axons, exposing neurons to toxicity. You know, materials in the blood are toxic to nerve tissue, and so on. There's also, as a consequence of the pressure from the blood accumulation, there's increased intracranial pressure. Inside of the cranium itself, there's a lot of pressure there resulting from the pushing, by the blood. And also usually there's swelling and so on, so there's a lot of pressure there. Another consequence or secondary effect is ischemic brain damage. When there's a pool of blood and the areas that are supposed to be there, that are taken over by the blood, are all pushed away from where they should be. And again, that involves shearing of axons, damage of cell bodies, and all of this, and exposing that to toxicity. And so you are going to have areas now. These areas would be ischemic. They wouldn't have enough blood. For example, they can't have access to food and blood. And in addition, the blood vessel that is supposed to supply blood to a certain area is now ruptured. And as a result, it doesn't have enough pressure to send blood to the areas it is supposed to, which causes ischemia or deprivation of oxygen and glucose. That is these areas will be ready to die. We don't say they are dead. When the death of these tissues occurs, we call this an infarction. And then hypotension again occurs because the blood vessel is leaking, and the areas that are supposed to be supplied, the blood is taken away from them and, leaking somewhere. So that is going to cause hypotension. And there's greater risk for meningitis because the blood-brain barrier is not working. And also, there are fractures that occur. So fractures are going to cause leakage of cerebrospinal fluid, and that leakage is it means that bacteria or viruses can enter through the cracks in the skull, the fractures, and they can go up to the brain, once they enter, they could cause a brain infection known as meningitis inside of the meninges or the 3 layers of the brain. And then breathing is, typically when the brain stem is affected, breathing is going to be affected. The person could be breathing in a shallow way, or breathing will be irregular. Also, heart rate will be affected as well, because these functions are regulated by the brain stem. And as the pressure continues from above, that is going to cause pressure on the brain stem, and that's going to make it unable to perform these functions. And in some cases, the brain stem itself is directly damaged. So again, you just think about the brain consistency, very similar to jello. And if you take that cup and hit it hard against a hard surface or a wall here, hit it from this end, the jello will be dislocated from the opposite end. So this is what happens in acceleration, deceleration, typically acceleration, deceleration accidents. Imagine this, is a brain of a person, and it is smashed due to when the head hits as a result of acceleration, deceleration. So the direct hit here is called the COOP, C-O-U-P, the COOP, the area of the damage itself. And for every COOP, for every area of impact, there is a counter COOP, 90 degrees across directly on the other side. You are going to have another area of damage called the counter COOP. That is described in your textbook. So this is what it is again, the local area that is directly hit. If you take that cup and hit it against the wall, hit it hard enough, then that area where the hit takes place is going to have accumulations of jello rising and hitting against that wall of the cup. In the meantime, if you go look back 90 degrees back, you are going to find an area in the back across from the COOP that we call counter COOP, where the damage takes place as well. So one accident causes, more than one causes damage in more than one location. If you work in the ICU, typical problems that you face with brain damage, and these are quite big signs of a basilar skull fracture. Basilar has to do with the base. The base of the skull is fractured because of, the bones, several bones are joined together to make the skull. And when you have a severe impact, some of these bones might separate. And the typical sign of a basilar skull fracture is the panda eyes or raccoon eyes, where the blood, the cerebrospinal fluid is going to leak out of the brain into the eye, around the eye. So, and it mixes with the blood, and that is going to cause that coloration, typical signs of a basilar skull fracture. There are several kinds of fractures, but this is particularly you are going to notice. And there's also battle sign fracture, where behind the ear, in the mastoid bone behind the ear, you are going to find this whole area here is like the same way discolored in dark, similar to the colors of these eye sockets here, and that's called battle sign scar. So you look for these scars in your patient. You look for panda eyes or raccoon eyes, and that will tell you if the patient has, and this can be the conduit for germs to enter, because now you have, in the nasal cavity and the eye socket, they are exposed to germs and all kinds of things, and this is one of the sites where germs and bacteria can penetrate and just go through the fracture to the brain, and that can cause meningitis. Let's look at the behavioral effects of TBI. As we speak about behavior, you need to think of language as a behavior. First, neurological and psychiatric effects. The person will have altered consciousness, and they would have paranoia, delusions, hallucinations, depression, apathy. A lot of this is coming from the frontal part of the brain and also the temporal cortex. Right hemisphere could also be contributing. So you would be among the first professionals to see a patient in the ICU. And you would be the first, basically one of the first people to do, to test consciousness and alertness and so on. The neurologist is also there. So, and physiological signs include dizziness, headaches, ringing in the ears, nausea, and vomiting, sensory impairment. The person cannot feel in a certain side, and sleep dysregulation, because usually the brain stem is the center for sleep regulation, but it regulates it with the frontal part of the brain. And if either the brain stem is damaged, or the frontal part of the brain is damaged, or the pathway between them, that is going to alter sleep, and it will also alter consciousness and awareness and alertness. Also fatigue. The person constantly is tired. There is a story, Harriet Tubman. If you are familiar with her life story, there's a novel about her. Harriet Tubman was a hero, an African-American woman who worked during the days of, when people were enslaved. And she worked on helping people escape from slavery and coming to the North. And one of the adventures she had, she was trying to help someone, or probably when she was trying to escape herself, she ran in a forest, and then she tripped and she fell, and her head hit a tree stump, or like the log, and she had a brain injury. And she continued throughout her life to complain, of these problems. But one of the symptoms that she had was she would be talking with you normally, and then all of a sudden she would just fall into a deep sleep. And that is one good example of head injury, and it, frontal particularly, where it alters your sleep. It dysregulates your sleep, and and also consciousness. So behavioral effects of TBI include confusion, like the person doesn't know where they are, and disorientation. They wouldn't know where they are. They wouldn't know, for example, the date. You ask them about their children, they might not know their wife or where they are from. So these are skills that you test using the mini mental status exam. You evaluate mental status, but using a screening tool. And in any hospital, you are going to find that a particular mini mental status exam, but you as an SLP are going to administer that frequently. And the two forms that I provided you should be good ones that you could use, or you could use the one that is available, in the hospital that you are placed in. So confusion, disorientation, restlessness, hyperactivity, because especially if the frontal part is affected, the person is going to have difficulty inhibiting their physical behavior, their motor behavior. So they can't control themselves. They will have anxiety. They would act, for example, may produce, childish behavior. Attention is impaired. Judgment is impaired. Memory is impaired. Thinking is impaired. One of the very common problems, especially with frontal injury, is that the patient might be aggressive. They might yell at you, they might swear, they might insult you, no matter who you are, a relative or a physician, but luckily these behaviors diminish gradually, phase by phase as the person continues to recover. So you watch for these signs. Dysphagia occurs in 25 to 75% of cases of TBI, and there's again the wide variety. It is just because of the diversity of the disorder itself. You do not know where it is going to hit, how it will hit, and how severe the damage is going to be. But typically, when you say dysphagia is affected, you must focus on the functions of the brain stem, because the brain stem is what regulates swallowing muscles. And you know that the cranial nerves basically innervate the neck and the neck muscles and the vocal fold muscles and the soft palate muscles and all of these because of the cranial nerves. And in addition, the centers themselves that control swallowing are in the brainstem. So whenever you see dysphagia, you are going to question, you are going to suspect that the brainstem is damaged. In terms of communication difficulties associated with TBI, of course, conversational skills and the ability to initiate conversation, cohesion, coherence, topic maintenance, turn-taking, clarity, all of these are frontal brain functions and also right brain functions. And depending on where the area hits, you are going to find them affected to certain levels. But particularly if the frontal brain is damaged, you can count on it, because when there's frontal brain damage, typically it's going to affect right hemisphere and left hemisphere, the frontal parts of both. And you can also, if it is severe, like a car accident or acceleration, deceleration, you can count on also parietal areas and what do you call them, occipital areas also affected, because there's coop and there's counter coop in the back. Verbal inhibition will be affected significantly, especially when there's frontal brain damage. Inhibition generally is a frontal brain in the prefrontal cortex. The ability to wait your turn. If you are impulsive, you can't wait your turn in line or in conversation. The ability to, for example, to say things at a particular time, wait, initiate things when you should initiate, and terminate when you should terminate, that will be affected. So there's behavioral inhibition and verbal inhibition also will be affected. The person would just have no filter. They say what's on their mind and will continue to insult maybe someone or just become impulsive or say whatever comes to mind. But again, as the patient continues to recover, you are going to see when the frontal part of the brain continues to connect with the rest, that is going to decrease the symptoms. The person might produce perseverative responses, like saying things more than once. For example, I worked with someone who would say, I spoke with my mom, I did. I went to the store, I did. I went to the store and I bought, and they keep repeating or saying something over and over. Impaired word fluency, that is because, can you guess why? Because of word recall. Working memory is affected. Working memory is required for you to recall words immediately when someone says them, or also to retrieve them from long-term memory. So in that case, you can look for these. These are big signs that will slow down someone's speech. Nonverbal communication is also impacted. facial emotional expressions on the face, and also using hand gestures and body language and so on. Reading and writing are also impacted, and the person might have auditory comprehension difficulties, or they might even have aphasia. Just keep in mind that aphasia is a non-progressive disease except for semantic dementia or primary progressive aphasia. Speech difficulties associated with TBI, the person might have dysarthria, they might have hypernasality. I'll explain when we speak about dysarthria why they would have the hypernasality. They might have imprecise consonant production and reduced breath support. Because the muscles that activate the respiratory muscles, the nerves will be affected, and that will decrease the ability to, to breathe deeply. Impaired emotional and linguistic prosody, especially if the damage affects the right hemisphere. And possible impairments in fluency, that's again in terms of how slow, for example, because of word retrieval, or if they would have apraxia, for example. So fluency can be affected in different ways in terms of TBI. The TBI team includes many professionals, including a neurologist, a radiologist, a primary care physician, an SLP, clinical psychologist. The clinical psychologist is someone who has a doctorate or a PhD in psychology. So they can, they work in hospitals, and in some cases, in some states, they can prescribe certain psychotic medications, or, for example, with depression, for emergencies and stuff, they can prescribe a few of these. So, but if you do not see the word clinical, usually it refers to someone with a master's degree, and they don't have these abilities, these functions. So physical therapy, nursing, social work, and other professionals based on the need. For example, if the need involves the cochlea, that means that that you would have an audiologist, for example. So it depends, but these generally the typical people who make a TBI team. In terms of diagnostic considerations for TBI, we need to get as much information as possible about communication of the patient prior to the injury. You want to know the extent of the injury. You ask, are there any videos, any phone messages recorded, things like that where you can hear the person or see the person communicating before. That is going to tell you how much they have lost. However, you do not use that as your baseline. You use, when you do the evaluation, collect all information you have about how communication is and the abilities of that patient after the head injury. That becomes your baseline. For example, let's say if they can, after the injury, they can follow directions with 30% accuracy. Like if you give them 10 directions, they will be able to follow 3, and then they wouldn't be able to, to continue. All the other ones will be inaccurate. So that is your 30% is your baseline. And then you work with the patient and keep working, and then you go back and evaluate. And when you say, for example, in 3 weeks, the patient is able to perform with 50% accuracy, then you compare 30 to 50, and then that is what you enable the patient to produce. So again, your baseline is what you get after the injury when you do the evaluation, and then you go from there, and relative to that point, that will show how far the patient has progressed under your care. You want to learn about medical issues, what is going on. Do they have any related problems? What neurological symptoms do they have? Psychiatric symptoms? all the entire health, profile you need to be aware of. And when in the ICU, typically, you are going to have the chart. And when you go day by day, everyone who comes in, you have the primary care physician, you have, the physicians who are supervising the case. They are going to come in, see the patient, go into a little, small office, write their report. And then before you go in to see your patient, you have to go to the file, read what happened before you came, who said what, who wrote what. You read all the reports that were written by the professionals who saw the patient before you, and then you go in and do your work and come back, go to the chart and document, put a summary of the findings that you have found in terms of your area. And the person who comes after you will read your comments. And so that is the means of communication with the team members. That is the primary tool that you use. And then, of course, if there's a need to meet with a particular person who, like a neurologist or, say, for example, a gastroenterologist or a surgeon, you need to then connect with them and easily, meet with them. But your chart, sometimes they say to nag the chart is to go in and write your notes in the chart after you finish. But before you see your patient, you have to read everything that happened in that day. So you need to evaluate orientation and alertness using the mini mental status exam. I hope that you reviewed the exams that I gave you. There are many forms out there, and but I felt that these two are quite good. You can administer a mini mental status in about 10 to 15 minutes, maximum 20 minutes. Evaluate communication and cognitive functions, and be prepared also again for inconsistent performance. You might go in, the patient is tired, the patient fell asleep. Maybe the patient, while you are working, to evaluate their swallowing, they just were eating and then they fell asleep, or they got tired, or they went to have some kind of procedure. They might not be fully awake or alert. They might have behavioral problems. So again, they might say something insulting to you, but these things again with progress, you see them early in the first few days, and then they diminish hopefully as the patient continues to recover. You also, so in addition to language and all this, you also have to get an idea about memory and reasoning and planning skills. Language evaluation, the language areas that you evaluate in terms of discourse and pragmatics and all, the areas that are explained in your textbook and that we have mentioned here. You also look for dysarthria, you look for dysphagia, as we said, 5 to 75% have dysphagia. You look for also in some cases apraxia, but it is less frequent. In terms of motor speech disorders, we focus primarily on apraxia and dyspraxia. There's a video here that if you watch, you'll understand the characteristics in a concrete way, characteristics of apraxia. There's developmental apraxia, and there's also acquired apraxia. So developmental is the child grows up and has it, and it usually improves with treatment and so on. But in some cases, it could remain throughout life to certain levels. And acquired praxia that might occur due to stroke or brain injury. So you need to be aware of the patient's medical history and what disorders the patient has in addition to communication problems, comorbid disorders. It is very important to read the reports, and especially the neurological report. That's going to give you a wealth of information, and day by day you're going to find reports in the medical chart of the patient. Refer to the general diagnostic criteria or features of apraxia on page 61 of your Hedgie and free text. Distinguishing apraxia from dysarthria, you will find page 67 gives you a lot of information. But generally, apraxia is an ideational problem. The muscle system is working perfectly. However, I might be sitting by myself and saying, pop, 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 or going like this or like that. I can do that. But if you order me, or ask me, in other words, to do these movements, I am not going to be able to do them simply on command. I would have difficulty translating what you say to a command for myself to move my muscles the way that I want to move them. So, this praxia or apraxia has to do with taking your intention for speech and taking the script of what you want to say, because the brain makes a script before you say anything, and taking that and bringing it to the motor cortex and making the motor cortex activate the muscles in the precise way that you want them to be activated. And then all the sounds will be produced in a particular sequence and the words produced in a particular sequence. That is normal speech. However, there is a disconnection or abnormality in the pathway connecting the prefrontal cortex with the motor cortex. So the planning areas are not connecting well with the areas of the primary motor cortex that actually you think of them like a button. Once you press that button, it is going to activate muscles and it will activate them in the precise way. So you can think of this like you have your computer, you have a program on the computer that connects with your printer. That's your software. So if you have the software, you can make the printer control. You can make the computer control your printer. So when you have a document and you want to print it, you are going to plan the document and write it down, and then you go print and press print, and whatever you have on that page, the document is going to be printed in exactly the same sequence, exactly everything that you intended it to be. However, in apraxia, that script that you have, that document you have, when you press the button, it gives you something different. You might be trying to say, headache. It might come as Quebec. So it might come randomly, or it might say bad. It might come as da or dab. So there's a disconnect between the idea you have for speech, the intention, and the actual area, the motor cortex that activates the muscles. This is why sometimes it is called it is described as an ideational disorder. It has to do more with the ideas, that the ideas are not reaching the motor cortex the way that they should be reaching it. They are not intact, and as a result, the outcome is going to be apraxic or impacted. So now we look at assessment of dysarthria. This is a little bit modified because so dysarthria. In dysarthria, the ideas are intact. The pathway is intact. You want to say something, you send it to the motor cortex. However, the motor cortex, even though it has the command, it has, the command to move these muscles themselves cannot do the job. The respiratory muscles are not working hard enough. They're kind of, there's a lot of paralysis, hemiparesis, weakness, muscular weakness in multiple areas of the body. So as far as speech is concerned, respiratory muscles are going to be decreased. Their function will be decreased. And the person cannot have a lot of air inside of their lungs. As a result, that's going to affect the loudness of their speech. it will affect their ability to make emphasis, to stress syllables, and to produce an emotional effect, to modulate their pitch and the loudness. That's going to have an impact. So it is all about muscles. Muscles are not working well, and as a result, the person has difficulty with speech. Again, they understand what they want to say. Everything is fine in terms of comprehension and meaning, but muscles are weak, and they usually are slow and have, a list of symptoms that we'll explain in a couple of minutes. But in terms of the etiology, there are many causes of dysarthria, including degenerative diseases. For example, ALS, PD, Huntington, all of these are degenerative diseases. Vascular disorders, like, say, strokes, or, for example, abnormalities in the blood vessel system. Traumatic brain injury, tumors, toxicity, neurotoxicity. The areas of speech affected in dysarthria. This is not apraxia, this is dysarthria. Resonance. When you speak about resonance, there are three ways that we refer to how the air inside of your vocal tract vibrates in response to your vocal fold vibration. That is resonance. And it has to do with the shape of your vocal tract and the configuration of your vocal tract. So there are three forms of resonance that we describe when we evaluate. Typically, you speak about hypernasality. In hypernasality, the velum is not sealing against the posterior pharyngeal port. So the velum is not closing well. Now, when you have hyponasality, the velum is closing, and usually there is adenoid enlargement, and there's not a lot of air exiting your nasal cavity when you say the nasal sounds. So hyponasality is lack of enough air or decreased air when you say nasal sounds like You don't have a lot of air exiting as it should through the nasal cavity, the nares. So it only affects, only affects these three nasal sounds. Hyper, it means that the air is leaking out. So here is the oral cavity, here is the velum, here is the posterior pharyngeal wall, and you want the velum to lift up when you say E, so air is directed to the oral cavity. However, the velum is not closing well, and air leaks when you say E, it comes out as E. One easy way to diagnose this, simply get a clear straw and put it inside, inside of the nair, and say to the person, say E or Ah. They shouldn't have any mist inside of the straw. Another way is to get a dental mirror, and we call it cold mirror test. You put it in the refrigerator. Sometimes it doesn't even have to be put in the fridge. You just put it there then and say to the person, say E. Obviously give them directions, and you say don't breathe until I ask you. You put it in there, because if they breathe, they're gonna have mist on it. So give them the directions and then put it under the nair, under the nose, and say E. If there is air, mist on the mirror, that means the person has hypernasality. Why the hypernasality occurs? The entire velum is a set of muscles. And when there's dysarthria, these muscles are also weak, and they just are hypoactive, and they can't go out and close the velopharyngeal port to separate the nasal cavity from the oral cavity. Hypernasality affects all sounds except for the nasal sounds. And then vocal fold adduction, again, weakness, muscle weakness. The muscles that control the adenoid I'm sorry, the arytenoid cartilages that that adduct the vocal folds. These muscles are also hypoactive. They are not able to just, compress the vocal folds and close and seal tight. So that is going to cause difficulty. It will cause air to leak out quickly. The person will run out of breath. Think about the video that we showed in class where the young man just speaks word by word by word, and every word he pauses to take a breath, and it makes his speech very, very laborious. Loudness is affected because of decreased lung volume. Intonation is affected because, again, the decreased air supply, it makes the person unable to build subglottic pressure beneath the vocal folds. So if you don't have enough air supply in your lungs, you will not be able to build up pressure beneath the vocal folds to make your voice louder, or to make your intonation, you raise your loudness up and down and modulate and have control over your voice. So that is, intonation will be affected, and it is your job to evaluate all of these areas and to see which one is, to what extent each area is impacted. Also, the person will have a slow rate of speech because of all the muscular weakness. You have to use about 90 muscles to make a single word. And imagine all of these muscles have weakness, some more than others, and that's going to produce that kind of, slow speech, labored speech, monotonous. The person is not able to express his, for example, to make stress, to emphasize, to make emotional expressions that can show they are angry or they are happy or excited, not because of the right hemisphere damage, but because the air supply is decreased and they cannot produce emphasis. So as a result, that is an area that is impacted. But again, it is different from right hemisphere damage. A consideration: it is very important to understand the medical history, to understand the diagnosis. There are 8 different categories of dysarthria, and you'll go through the process when you study motor disorders. You are going to study all of these, so no need to really worry about what kind of dysarthria are we dealing with and stuff. That we haven't discussed this extensively, and I wouldn't hold you responsible, for that differentiation in this class. But when you study motor disorders, you will have to distinguish between one kind of dysarthria and the other. So you look for the neurologist's report and read it carefully to see what the diagnoses are, because the diagnosis typically is made by the neurologist. Look for the site of lesion and understand how that site of lesion affects language production or language reception. But understanding these reports and the history and the medical characteristics or background of the patient, that's going to enable you to produce a precise differential diagnosis, to pinpoint exactly what kind of dysarthria do we have. So this brings this unit to conclusion, and I hope that you find it helpful, and thank you and best of luck.